Hi, this is Scott Morgan. I'm here with the latest in my weekly Echo Tip series. Many times during our careers, we do a lot of portable echoes, whether it's in the ICU or trauma or tele or wherever it is we happen to be. If your time and situation allows, there are a few basic things that you can do to save you time and to save your body some pain. Things you need to know. First one, why are they in the ICU? Is it a fractured hip, a fractured shoulder? That can set you up for understanding what you're going to be able to do and what you're not going to be able to do. Are we looking for the proverbial LV function, or is it something different like aortic stenosis or mitral stenosis or whatever? It can be lots of different things. It also gives us a chance to look at the order and see what their BMI is. What's their height? What's their weight? What are we getting into here? What's their surgical history? Is it an AVR? Have they had a recent TAVR? Are they just done with an ablation? That can tell us a lot of why we're doing it there. What's their previous echo look like? Can we see any reports? Is it something recent, like just this week? Or is it something that's more remote? Is it maybe just a limited echo today? I have a challenge with my providers getting them to tell me why we're doing a limited echo. That's very important information, and sometimes I have to do a deep dive in the chart to even find it. Now, once you've kind of figured out why you're going and what you may be facing, it's time to head out to the room. These examples show a pretty standard setup for either left-handed scanners or right-handed scanners in an ICU situation. All of my patients, and I'm sure yours as well, are skinny and easy to scan in the ICU. Getting the bed to the right height is often one of the very critical things you can do to help with your ergonomics and help you be able to do this in a more pain-free and less time-consuming manner as far as probe time. The nurse can often help with the wedges or positioning the patient, and it's useful to know when and if the patients need to be turned again. Very often you may walk in at just the right time to get them tipped up on their left, or you may need to come back in an hour or so. These examples are a little different way of looking at things, and I've always described it as just scanning when you're facing the patient's feet. While it's very different, it can save the day in some rooms and situations, and can also save our arms. It does use some new muscles, and it may take a little bit of getting used to, but try it, and I'll bet you'll find out that it helps in some cases.